Okay, thank you. So, hi everyone. My name is Ariane. I'm a cardiologist. I work in Brazil. I will present now some issues about COVID-19 that I feel that is a problem that our world is facing and facing again. Here we are dealing with a very big problem now again, so because of the cases are increasing. So what I would like to present are some issues about the relationship between SARS-CoV-2 and the renin-angiotensina system. And here in Brazil, we had the opportunity to run a trial during the first wave of the epidemic, that it was the Brace Corona trial. And because just at the beginning of the pandemic, we realized that the ACE2 pathway could play a role in the inflammation and all the problems that we have been facing in COVID. So what I would like to present is a review about the relationship between the ACE2 system, COVID-19, and also cardio-oncology, because this brings, after we start studying more the ACE2 system because of the COVID-19 is not a new issue, that we know that the ACE2 pathway has a role in all kinds of inflammation and also in the tumors, in the expression of the tumors, and also in the response for some kind of tumors. So really it was something that brings to us again to review that, and also to propose some mechanisms and possible mechanisms in the future to treat cancer using the block of the pathway of the ACE2 and inhibiting the ACE2 pathway. So just to remember, I feel that is not necessary to review what we are facing now, the epidemic. Millions of people have died. Some hospital systems are overcrowded. We had a relief some months ago, and unfortunately, we are facing this problem again. So also it's important to review the mechanism of the infection by the SARS-CoV-2, and how important it is the ACE2 receptor for binding the virus and to internalizing the virus. And doing that, all the mechanisms that now we are facing in trying to treat this disease is based on all the mechanisms for replication and also to treat the cytokine storm that we are seeing in our patients. But let's start reviewing how the virus entered the cell, all the spikes that the coronavirus has can bind to the receptor of the ACE2. This is a key role of these mechanisms. Just a minute, I just need to turn on this thing here. And this is a very important mechanisms of entering the virus in the cell. So after that, the virus need to be a translation, all the proteins that are necessary for transcription, and also to replication in another virus, and the virus is released and can contaminate other cells and spread the disease. So now what we are doing is trying to treat the virus and the infection, fighting against these mechanisms approved in the United States, not approved in Brazil. We have remdesivir that inhibit the transcription of the virus and also can block this replication and the cycle of the virus inside the cell. So all these mechanisms are now more clear here. Again, the importance of the SARS-CoV-2 binding to the ACE2 receptor has a key role in the development of the disease, and all the treatments again that we are using is to treat the infection and also trying to inhibit this replication. The results has not been so far stimulating. The chloroquine that it was thought at the beginning that could be a drug to treat, but now in Brazil and around the world it has not been approved. And in 2-3 big trials, one of them, the Coalition 1 and Coalition 2, that it was Coalition 1 and Coalition 2 that had been published in New England this year, that were done here in Brazil. We demonstrated that hydroxychloroquine with or without azithromycin is not effective in blocking and the evolution of the disease. So this is not an option anymore. So saying that, it's important to review the ACE2 expression through our body. And this is so interesting because after the COVID-19, we start to studying again this molecule that is so important and has a play role in all our cardiovascular system. We know that ACE2 is expression in practically all systems in our body, but in the heart and the vessels, it has a play role in the internalization and not only to the virus, but to having these sites in how the ACE2 receptor works with the angiotensin system is very important. So for COVID, what we know regarding this renin-angiotensin system, we know that once we have the virus internalizing the receptor, we have a reduction of the expression of the receptors. But we know also that ACE2 plays a role in the conversion of angiotensin 2 to angiotensin 1 to 7. And these two proteins, these two agents have different roles in the cardiovascular system. We can say that we have a bad one, that's the angiotensin 2, and we have a good one, that's angiotensin 1 to 7. The angiotensin 2 that we know very well is a molecule that binds to the A21 receptor. And when this pathway is activated, we have a detrimental and a maleficy in our cardiovascular system because it's related to vasoconstrictive mechanisms and also developing free radicals inducing fibrotic state and also hypertrophy of our myocytes and our cardiovascular system. So we have been through years trying to block this system using ARBs and also to block this conversion using the other drugs to trying also to reduce the levels of angiotensin 2 and increasing the level of ACE1/7 because this molecule, when binding to the MESR receptor, has an opposite effect with protective mechanisms, inducing antifibrotic, antioxidant, antipetrofin, and vasodilatory system. So when we start seeing the importance of ACE2 to the coronavirus, the first thought for us, it was maybe when we are using agents that can interfere in this system, like using the ACE inhibitors or angiotensin receptor blockers, we can interfere in these mechanisms. Since we have a reduced level of ACE2 receptor induced by the virus, maybe drugs that will increase the viability of these receptors could increase the risk to have COVID. This it was the first thought at the early beginning of the epidemic. Maybe patients that were taking ARBs and ACE inhibitors that we know that increase the levels of the ACE2 receptors as a contra-reversive effect, they could increase the susceptibility to COVID-19 and maybe doing these patients being worse, because we realized at the first beginning that patients with hypertension were at increased risk of intubation and death. So this was at the beginning. We as a society, the American Society of Cardiology, and also European, Brazilian, around the world, were not taking this as a really true. All the patients, we were saying to keep the medications because all the benefits that ACE inhibitors and ARBs can have in our patients. But the results of the trial in that beginning April were not yet available. So we were reviewing and discussing these mechanisms because the play role of the angiotensin system has to the infection of COVID-19. And we know also when we were realizing the population at major risk to have a bad evolution of COVID-19, we realized that could be also a link between this population and the expression of ACE2. We know, for example, that diabetic patients, hypertensive patients, obese patients, and patients with some kind of pulmonary disease could have an increased risk of a bad evolution too. And what we know is that this population also has increased expression of ACE2 in their cells. And when we block this system and when we reduce the level of ACE2, doing that, we reduce the conversion of ACE2 to a conversion of angiotensin 2 to angiotensin 1 to 7. So doing that, we increase the levels of angiotensin 2 with all the bad effects that this substitution has, and we reduce the benefit of angiotensin 1 to 7. So all the mechanisms that were related to this to the reducing of ACE2 could increase the risk of COVID-19, and there were coincidence about this expression of ACE2, risk of COVID, and also the bad evolution of this disease during the pandemic. And we start again taking a look in the cancer patients. We know that also the cancer patients were at increased risk of a bad evolution of COVID-19. And again, ACE2 were involved in that. We have some private studies showing that the expression of ACE2 in cancer patients, mainly lung cancer patients, that had already been shown that these patients had an increased expression of ACE2 in the tumor cells, because ACE2 can induce also the activation of the angiotensin system, can induce the increase of growth factors like VAF1 and TNF. We know that this is increased in these patients. And in this small study, they could see in a molecular level that there were in some types of lung cancer an increase in the expression of these receptors, maybe increasing the susceptibility to lung cancer patients to have a bad evolution and more increased incidence of COVID-19. Really recently, another study published in the Cardio-Oncology study has shown also that some kind of cancer patients, kind of in a molecular study, has been identified as increased expression of ACE2 and maybe also increasing the susceptibility to COVID-19. This was very well expressed in this study when they showed that the levels of ACE2 is expressed in the tumor cells were increased in patients with kidney cancer, pancreatic cancer, colon cancer, stomach cancer, lung cancer, and when these patients when these tumors were seeing the DNA methylation, these expressions were very increased in these patients, and maybe this could show us the problem about this susceptibility to lung cancer for patients to COVID-19. I'm just reviewing this data. We know that this expression, ACE2 expression, increased in this lung cancer compared with other tissues, was independent of the stage of the disease, and could really show us increased susceptibility to SARS-CoV-2 among these lung cancers regarding the age. So what we did here in Brazil, facing this problem, we decided to perform the BRACE Corona trial because regardless, all the societies and all the retrospective studies had shown that using ACE inhibitors and ARBs were not related to a bad evolution and also to increasing the risk of COVID-19. There were equipoise in all the possibilities of this relationship between HARS inhibition and COVID. As we have seen, we know that ACE2 and ACE2 is increased in patients using ACE inhibitors and ARBs, and this could increase the susceptibility to COVID with a bad evolution. But also we know that when we are using ACE inhibitors and ARBs, we can reduce the expression of angiotensin II and increase the expression and the role of angiotensin 1-7. So using these agents, we could increase the angiotensin 1-7 by ACE2 activation and activation of the MARS receptor with a benefit. So malefic or benefit, that we didn't know yet. This is the publication of the design paper, and we roll this paper, we roll this study that it was presented in the European Congress of Cardiology. This was the design, the BRACE Corona trial. We perform an intervention of suspending ACE inhibitors and ARBs in patients using that were hospitalized with coronavirus infection. So we start with 500 patients. We finished with 659 patients. The intervention was very simple. We decided to randomize this patient to continue the ACE inhibitors and ARB treatment during the hospitalization for COVID. And on the other group, we decide to interruption the use of ACE inhibitor and ARB for 30 days. 30 days during the hospitalization, if the patient was hospitalized for more than 30 days, during the hospitalization, after the discharge at home. And our primary outcome was the median days alive and out of the hospital at 30 days. We had a telephone call with these patients. Some of them were in our clinic that we were following, and we are still now. And we take a look in all these secondary outcomes, trying to really identify what were the role of angiotensin II, angiotensin renin-angiotensin system in patients with COVID, if all our orientations to the patients to not stop the drug were correct in a randomized trial that was presented in the European journal, in the European Congress. I will show the official slides in the presentation. Just to finish this. So we finished the trial and presented by our colleague, the Professor Lopes from Duke University, and that it was a co-share study. So the background I had already presented, the ACE2 expression, upregulation in patients using ACE inhibitors and ARBs, the conflicting observational evidence about this role, the ECPOs, about being benefit or maleficent to the patients with COVID. So it was the trial. It was a multi-center phase 4 randomized clinical trial. We included 659 patients to these two groups, suspend for 30 days, continue the treatment. And our primary outcome was days alive and out of the hospital at 30 days. These patients could not be hospitalized due to decompensated heart failure in the last 12 months. They could not be using more than 3 antihypertensive agents because, of course, here we had to replace the drug that this patient were taking. It was not difficult to control the hypertensive patients, but if the patient were already taking more than 3 antihypertensive agents, our possibilities to change or to increase the dose were limited. So we decided to exclude these patients. Patients under Entresto also were not included, and of course patients with hemodynamic instability, since the hypertensive drug must be suspended in these patients. This was the group that ran this trial, and our endpoint was the number of days alive and out outside the hospital through 30 days. This represents the follow-up time of the 30 days minus the hospitalization days. And this it was a very important point when we were planning this trial, because we had short time to perform. We had no idea how this disease could run. We start planning this trial in March this year. So really it was very unlike for us what we could expect. So we decided to be conservative. We decided to really see not the kind of usual endpoints, but what it was important that time is that the patient could be discharged and could be out of the hospital, and we decided to have this endpoint to be done. So some details about the statistical analysis, and these are our timeline. So we developed a group to develop the protocol in March 21. We randomized the first patient April 9. We had the last patient randomized in June, the end of the June. We had the last patient call and visit in July, the end of July 26. We closed the database in August, and on September 1st, we present our results in the European Congress of Cardio-Oncology as a late break. So that's what we get. We get this trial. We were running a register about COVID-19 patients in some hospitals in Brazil. So we decided to use this data because all these patients were included in the COVID-19 register. And we picked the hospitals with that were a hub for COVID, because our country has a great extension, so it was not possible to include so many hospitals as they want to be included, but we had to decide 30 hospitals around Brazil were included. So having these patients with the criteria of inclusion, we end up with 659 patients included that were randomized for the two groups, suspending versus continuing ACE inhibitors and ARBs. And we have 100% of complete follow-up, and we have 9 patients. We lost 9 patients that died in each group. This is interesting about the baseline characteristics that is reflecting really the population for COVID in our country. We had a young population at the median age of 55 years. The majority were men, as had been shown. This profile of COVID-19 is more present in men, maybe because some hormonal issues that has been already published. Very important and consistent with recent data that were published recently on obese population. We had a median BMI of 31 in these patients, and this was really interesting, because when we are running this trial in the hospitals, it was frequent to see that the obese patients, young and obese patients, were very frequently in the ICU with the necessity of supplementary oxygen. So at the end of the trial, we come up with this data, and we checked a lot of times the result, and we come up with the perception that is true. Really, is that obesity is a risk factor for a bad evolution and the necessity of hospitalization in COVID. And we had a paper in circulation 3 days ago about the data in the United States showing really that this is the profile of young patients hospitalized with COVID. Obese patients had an increased risk of hospitalization and ICU necessity and ventilation, artificial ventilation. Our population were 100% hypertensive, a small number of heart failure patients, and our others characteristics were well distributed between the two groups. The majority of the patients were under ARB. We have only 21% of patients under ACE inhibitors. This is something that is very frequent in Brazil. The majority of patients, because of the side effects of ACE inhibitors, usually they are taking ARBs, and this was consistent with in all of the centers around our country. And in the median 5 years of previous use of ACE inhibitors and ARBs, the majority of the patients were presented with the classic symptoms of COVID. We had almost 1/3 of the patients with presentation with oxygen saturation under 94, and a median of time to the symptoms to the admission of 6 days, showing really that we were including the patient in the phase of worse of the ventilatory and the cytosine storms, really. We have a population with a median of CT involvement of 25.6% of the lung were involved in our group. 100% of these patients had a CT on admission, and the majority of these patients were at mild to moderate severity of COVID, according to the CDC classification of this disease. So what we get about the primary outcome of days alive and out of the hospital, there were no difference between the two groups, a mean difference of 1.1 day among the two, between the two groups, showing really that is not necessary and don't impact in the days alive out of the hospital, stopping this medication when the patient got COVID, and have the necessity to be hospitalized. About the clinical status at 30 days, we have 91.8% of the patients in the suspending group were alive and out of the hospital at 30 days, and something very similar in the group without the intervention, continual ACE inhibitors and ARBs. So this was a very interesting result showing that this did not impact. Also in the mortality, we can see a tendency to be better to continue, but there are no different in the, there are no statistically significant difference, but really the results that we will show in the paper that will be published soon. We had not time to finish finish all the details to publish it simultaneously. It was really in the middle of the epidemic. It was a nightmare to do all the things and to get the data and to get all the data, and also to perform all the analysis to present so short after short time at the European Congress. So really, but now will be published soon with all the details. But we saw really a tendency to be better, to continue in these patients, and all the subgroup analysis that will be presented after in the paper will have more details about this. So to conclude, our conclusion in this trial addressing this issue about ACE inhibitors and ARBs in patients with COVID and all the mechanisms involved in the ACE2 pathway, we concluded that in patients hospitalized with COVID, suspending these ACE inhibitors and ARBs for 30 days were not impacting in the number of days alive and out of the hospital. We were happy that our data were in the same pathway, in the same direction of all the retrospective data that had been published in more than 9 or 10 studies, but all of them retrospectively. So we were glad to show in a contemporary and randomized trial really the evidence that is, as far as we know, it was not necessary to stop these drugs, and maybe can have a benefit to continue that we will see in other trials that are coming soon again also. So this was what I would like to show to everyone about our results, and also about the mechanisms of ACE inhibitor, and also our correlation with cancer, since maybe knowing better this pathway, we can find another target to treat also our cancer patients. Reducing inflammation maybe had some impact in the cancer outcomes. So thank you for your attention, and again, sorry for my delay at the beginning of this web meeting.
Ariane, thank you so much. This is Dan Lenahan in St. Louis.
Hi.
Thank you so much for your presentation, and I know you guys are having to deal with the coronavirus very frequently. So we are very concerned about you, and thank you so much for taking your time out of a busy day.
Yes, has been a nightmare again. So sad about that.
Yeah, no, and could you explain two details for me? One would be, have you changed institutions?
The institutions, sorry.
Yeah, like where you work, are you working in a different place than ICESP?
Yes. Carolina works in ICESP. I'm working in EDOR, that is a research and teaching institute of Rede, and Carolina were working in São Paulo Institute of Cancer. This is Ariane talking.
Yeah, no, I know that. Right, but that's not where you were before, right? So you recently changed, is that true?
Yes. We changed to this institution that this is the biggest private network of hospitals in Brazil, and they are we performed this trial because of this network of hospitals, and also we are uh, improving and growing the cardio-oncology in more than 40 hospitals around Brazil.
Wow, that's great. Well,
Yeah, we are
congratulations
happy.
on that. I assume that was a good move for you. I
Yes,
know.
I'm working a lot and I'm happy doing that.
Well, and then the other question really is, what was the motivation to do this study? I mean, I think this is quite a heroic effort. The, you know, the it seemed as though to me, we saw a lot of patients with heart failure, and then if they got exposed to COVID, then, there was all this at one point, at least early on, there was all this concern about some ACE inhibitor or ARB interaction. But, I never really understood why there was such concern for that. I know you showed the mechanistic slides, but I mean, I just didn't really feel like that was likely to be a very important mechanism. So,
Yes.
what do you think was the motivation to be so concerned about it, to do this study?
Yes, we were concerned then because when we realized so many institutions and also societies being so sure about that it was not necessary to interrupt the ACE inhibitors and ARBs. And we were taking a look really in the physiopathology of the ACE pathway and how it's important to COVID. We realized we are not so sure. We know nothing about this disease. We were in March, so we had less than 1 month of the disease. How we can be assuring with the mind so peaceful that is not harmful for these patients. People were dying. We were starting to see these patients, young patients dying, and some colleagues dying with inflammation. That what takes our attention at the beginning, still now, but how they were with the cytokine storm. So why they are so sure about this mechanism that is not important. The drug that is prescribed in the majority of our hypertensive patients. And since the Chinese colleagues sent a letter to Lancet, I remember reading this letter that they were correlating the evolution, a worse evolution in patients taking ACE inhibitors and ARBs. Of course, it was a very small and retrospective drug, but this we are not comfortable with the results, even of the retrospective studies that were published after we had started the beginning. So I feel that it was the motivation were a group that you know us, that we are very close each other among our group of doctors in Brazil, and we communicate, and really we decide to do that. We said we will show the reality in the randomized clinical trial. That's the right way to do things. So it was really a very engaging study with people including more than 50 patients a day. So because of this effort, we were able to finish in a short time and with quality of the results. So it was we were not really sure that it was not necessary to stopping. It was not necessary to stop these drugs, but I feel that now we are comfortable to keep these medications.
Yeah, no, I mean, I applaud your efforts. That is really fantastic. And, it's a real testament to your commitment to the best patient care and with actually providing meaningful evidence instead of instead of just kind of an opinion. So really fantastic, amazing.
No, thank you. Then we are expecting the publication because we have so many details to show everybody about the subgroup analysis about the cancer population. There were not a lot of patients with cancer. Really, we had a young population in this trial. That really it was the population in Brazil. We know that in the United States and Europe we had an older population, but really here our lockdown was early in the pandemic. So really the young people that come out home to work. So our population was younger really. And now we are looking forward to have the paper to present and everybody to read and get the conclusions that are really very interesting.
That's fantastic. Can you tell me where you submitted it, or where?
Oh, I can't yet.
You can't? Okay, no problem.
You know how it works.
Yeah. We will keep a close eye out for it, and as soon as you.
Yes, we are working hard.
Yeah, please let us know. And
yes, I will be happy to show.
Yeah, we'll post it on the ICOS website and everything. So yeah, we really.
And what it was interesting then that I asked to present this data was when we start studying a lot the mechanisms, and then we come up with a lot of cancer mechanisms about expression of ACE2 in tumor cells in lung cancer. And also I hadn't time to get the paper, but I read 2 weeks ago that a retrospective study in patients under immunotherapy founded by NCI, National Cancer Institute in the US, they showed a better response to immunotherapy in patients taking ARBs and ACE inhibitors. Of course, retrospective and so, but really pointing out this benefit for inclusive to patients with immunotherapy. So I feel that ACE2 and ACE pathway is on the spotlight of the science, and we should maybe use more these mechanisms and knowing more these mechanisms to find another target for therapies.
Yeah, no, that's a great point. Yeah, really fantastic, and we greatly appreciate your efforts breaking away from the battle that you're in. So thank you.
Yes, it was like we are driving the car and also fixing the problem. It was like trying to
change the oil while you're driving the car. Yeah.
Yeah, maybe it was really, but okay. Sometimes we just need to do. We're not thinking how, just do.
All right. Well, thank you so much. I don't know if there are any other questions out there.
I can't see the screen. I will show
Lalitha,
it here.
do you want to ask your question, Lalitha Medpali?
I was just wondering, is the ejection fraction taken into account, because that makes a significant role? I don't know if you all can hear it, but.
Oh, sorry, I could hear the start of the question.
The ejection fraction, was it considered, the EF, because the ACE inhibitors and ARBs may, have beneficial role in patients with reduced LVEF. I mean, I may have missed it, but it is not seen in the.
Yes, it was not
inclusion or exclusion.
Yeah, it was not exclusion. We would like to include patients with heart failure with reduced ejection fraction, but what we had at that moment is that these patients usually were more hypotensive when they got the hospital, and we excluded a lot of these patients for the trial because of the exclusion criteria. But we have 2.1% of patients with heart failure, with reduced heart failure. We are not able to perform a subgroup analysis because of the low number of patients, but it was a concern. So at the beginning of the trial, we decided not to include patients with hospitalization the last 12 months. It was a criteria to exclude these patients. But unfortunately, we had a low number to perform analysis.
Okay, thank you so much. Say hi to all of our good friends there in Sao Paulo, and please stay safe. We appreciate it.
Thank you, Dan. Thanks, Steve, for the opportunity to present and to be among our colleagues here. Thank you. Thank you for the opportunity.
Thank you so much.
Thank you so much.
Thank you, Steve.
Everyone have a good day. Thank you for joining.
Thank you. Thank you.
Bye-bye.